It's so nice to be able to say I don't stand between you and your lunch. So if anything, your lunch is holding you captive right now. My name is Kerry Cooper. I'm the Senior Vice President of Medical Affairs with Vera Therapeutics, and it's truly an honor and a privilege for Vera to be able to be a sponsor of this inaugural GlomCon meeting. What a delightful location for a meeting, despite the long travel from the East Coast. Most importantly today, I have the privilege of being the lead act for Dr. Richard Lafayette, who has already been introduced to you. In addition to what you've heard about Richard, he's also the co-chair of our Origin 3 Phase 3 study of Atacicept in IgA nephropathy, and he's going to be reviewing our most recent clinical data, which he had the privilege of presenting for us at the ERA-EDTA in Stockholm. So I'm just going to be setting the table a little bit by speaking about BAFF and APRIL and their potential roles in the pathogenesis of IgA nephropathy and the potential role of Atacicept as a novel agent for treatment of IgAN by interfering with both BAFF and APRIL signaling. Of course, this is a Vera-sponsored symposium with the normal disclosures. Atacicept, of course, is not an approved therapeutic agent and is currently undergoing clinical investigation for the treatment of IgA nephropathy. A lot of what I'm going to say is tremendously simplified background for most of you. This is an interesting group of glomerular disease experts. I wish an organization like GlomCon existed when I was a younger nephrologist, but it's so exciting to be in this fast-paced world of emerging therapies and glomerular disease, and just so much fun to be amongst a lot of colleagues and experts in the area. I hope to be able to spend some time with you over the next couple of days. I'll be here through the entire meeting. So as we know, IgA nephropathy is a progressive chronic glomerular disease. It's the most important or most common cause of primary glomerulopathy in the world. Of course, we can only estimate its true prevalence since, as we all know, the diagnosis can only assuredly be made with a kidney biopsy demonstrating the typical pathology. And because the threshold for biopsy obviously varies by geographic region and suspicion of the underlying disease, probably the true incidence is a lot greater than we currently consider. And we have to wonder, as more and more therapies become available for IgA nephropathy, and as we look at some of the epidemiologic evidence that suggests that this disease may be a much more severe renal disorder than perhaps we previously thought, I strongly suspect that the frequency with which IgA nephropathy is diagnosed is likely going to go up. We all know that this is a disease different than some other renal diseases that occurs more so in the younger population, not pediatric, obviously, though it can be a pediatric disease. But typically, most common age of occurrence or diagnosis is in the mid to late mid-30s or so. And of course, there's a geographic distribution of this disease, which is also a little different than some other glomerular diseases, and no need to overemphasize, this is especially common in Asian populations. The clinical spectrum of IgA nephropathy at the time of first diagnosis is also extremely variable. This can range anywhere from variable degrees of low-grade to high-grade proteinuria, microscopic, macroscopic hematuria, but of course we know there can be severe forms of the disease which are associated with severe proliferative glomerulonephritis, potentially even crescentic glomerulonephritis with rapidly progressive renal failure, though of course that is somewhat less common. I think the biggest message that we've all heard over and over and over again, and one of the reasons why IgA nephropathy has become such an important topic of recent discussions, is our understanding that patients with IgA nephropathy, who are most frequently diagnosed relatively young in life, have a rate of progression of disease that puts the vast majority of them at risk for the development of end-stage kidney disease end-stage kidney failure during their lifetime. This progression is maybe not as rapid as some other diseases like vasculitis or lupus, et cetera, but nevertheless, recent epidemiologic data, some of which I will go over in a moment, and which I'm sure most of you have seen before, tells us we really need to start paying attention to this disease in its earlier stages. Now, this is not meant to be a course in renal pathology, and I'm really looking forward to the lecture coming up in the next day or two on the pathology and treatment of IgA nephropathy, as our experts will go over. But needless to say, this is a disease that is diagnosed by kidney biopsy, showing the typical proliferation of mesangial cells, increase in mesangial matrix in its most typical form, though as we've said, this can range anywhere from minimal changes to severe crescentic glomerulonephritis. Of course, the hallmark is the immunofluorescence findings of IgA, typically with certain degrees of IgG and complement staining in the mesangium of the kidney as, with associated immune complexes in the mesangial region. Again, because of the lack of real biomarkers for this disease and thresholds to biopsy patients, we can have certain suspicion of this disease clinically in patients. I think I was always trained many, many years ago when we saw occurrences of hematuria, especially macroscopic hematuria, after respiratory or infections, that thinking of IgA nephropathy was especially a common diagnosis to consider. Now we realize this may be just a presentation of low-grade hematuria and proteinuria, and as we speak with colleagues around the world, if you screen for this disease, especially in younger populations, I think the prevalence may be much higher than we think about. Now, maybe the most fundamental change in thinking regarding this disease is thinking about its immunopathogenesis and realizing that the B cell is the upstream culprit that we need to think about in IgA nephropathy, and think about IgA nephropathy as a B cell mediated kidney disease. And if we go to the far left, I'm going to introduce the topics of BAFF and APRIL. BAFF is an acronym for B cell activating factor. You may also see in the literature this called BLISS, which is B cell lymphocyte stimulating factor, the same entity. APRIL, a proliferation-inducing ligand. Both of these cytokines, which are members of the tumor necrosis family, are thought to be the proximate stimuli to B cells and subsequently to plasma cells in stimulating the production of the culprits that ultimately lead to the pathology that we just described in the kidney. So remember, one of the truly interesting and unique aspects of IgA nephropathy is that both the antigen and the antibody, the antigen being Gd-IgA1, galactose-deficient IgA1, and its associated autoantibody, both come from activated B cells. And in this case, and we'll go into a little bit more detail about Gd-IgA1 and what makes it antigenic, the antibody and antigen in this case obviously ultimately form immune complexes, which are thought to deposit in the mesangium of the kidney, subsequently leading to the downstream inflammatory changes in the kidney, which can progress to worsening kidney failure over time, and are associated with clinical hallmarks, which include variable degrees of hematuria and proteinuria. So let's spend a little bit more time on BAFF and APRIL as we've just described. Again, they're members of the tumor necrosis family of signaling proteins. And this cartoon really depicts the fact that BAFF and APRIL are able to signal to both B cells and plasma cells. There are a number of receptors on B cells and plasma cells that are able to signal with BAFF and APRIL. I'm not going to review this biology extensively, but what I want to call out is the fact that the TACI receptor, which has a very long name to its acronym, which I'm not going to repeat right here, but the important part is BAFF and APRIL are both able to signal through the same receptor, the TACI receptor, stimulating ultimately B-cell proliferation, promoting B-cell survival and maturation, and another important aspect is switching IgG class to IgA-producing cells. Dr. Lafayette, in a moment, when he presents his data, will review Atacicept a little bit more with regards to its mechanism of action and how this actually ties in. And what we now know is that both BAFF and APRIL appear to be able to independently and synergistically stimulate the maturation and survival of B cells and plasma cells. And there's a large body of literature that I can't review in detail today, obviously, but there is evidence that both BAFF and APRIL independently play roles in the pathogenesis of IgA nephropathy. Whether these are so-called redundant pathways or whether either one of them alone is adequate to produce the disease is not completely understood. But a couple of lines of evidence support why both of these pathways are clinically important. In patients in clinical IgA nephropathy, both BAFF and APRIL levels are elevated and have been associated with the degree of disease activity that's present. Interestingly, in animal models, especially transgenic models, activation of either BAFF or APRIL pathways is able to produce a phenotype that is extremely similar to that seen in IgA nephropathy. In certain experimental models of immunologic renal disease, blockade of both of these pathways is necessary to adequately prevent disease. And it's based on this sort of logic that we believe that dual blockade of BAFF and APRIL may offer an optimum way to treat IgA nephropathy. I'm not going to review this slide in detail other than it reminds me to state one important point. We've sort of alluded to the 4-hit hypothesis, which was in the cartoon that I showed earlier, the production of Gd-IgA1, autoantibodies, immune complexes, and renal deposition. That's the most commonly accepted schema for the production of IgA nephropathy. But there's one point I want to make on this slide, which is, as we know, it is the mucosal-associated lymphoid tissue in the gut and in the respiratory mucosa that appears to be the common site of activation of these B cells that ultimately produce Gd-IgA1 and associated autoantibodies. The simple point I wanted to emphasize is these cells don't stay there. There is mistrafficking of these cells from mucoid lymphoid tissue to systemic locations, which include the general lymphatic system. But interestingly, there's also evidence that these cells may migrate directly to the kidney. Heather Reich's work from Toronto has shown some interesting data that suggests that you can actually find these IgA-producing plasma cells in the kidney itself, and it's provocative to speculate that they could have a local role in the pathogenesis of the disease. I'm going to just real quickly summarize what we think are the clinical hallmarks of this disease and their potential areas for us evaluating in clinical trials. I've already mentioned the elevation in galactose-deficient IgA1. Hematuria, we heard it mentioned this morning, we know it's especially prevalent in IgA nephropathy and maybe uniquely so compared to some other clinical diseases. Proteinuria, a clear hallmark of the disease, as well as decreasing kidney function. Galactose-deficient IgA1 is exactly that. It is a poorly glycosylated form of the normal IgA antibody. The deficiency of these glycans is in the so-called hinge region, and simplistically to say, the deficiency in those glycosylated areas renders the IgA itself immunogenic and therefore leading to an autoimmune response. In IgA nephropathy, the relative prevalence of Gd-IgA1 versus total IgA is disproportionately elevated. There's a tremendous amount of debate in the literature whether Gd-IgA1 itself is a good biomarker. Is it clearly diagnostic of the disease? I think we all know the literature that says in families of patients with Gd-IgA1, with IgA nephropathy, elevated Gd-IgA1 itself is not a marker of disease. You clearly need antibodies and immune complexes to develop the clinical syndrome. For sake of time, I'm going to go through these relatively quickly because I really want to get to Richard's presentation, but there is literature that supports the relationship of Gd-IgA1 levels with the severity of the disease, and also that the levels of immune complexes and autoantibodies also correlate. That being said, as we look at clinical trials, measurement of Gd-IgA1 is by far the most common marker that you will see, and that's not because there isn't great interest in the antibody or immune complexes. The confidence in measurement of those has not advanced to the same level as it has been for Gd-IgA1. So what about hematuria? Well, hematuria simplistically can be thought of in IgA nephropathy perhaps as an end-stage sign of inflammation and damage to the capillary loop. Obviously, you can't get red blood cells in the urine normally unless you have some rent or discontinuation in that in the endothelial filtering structure. And the ultimate mechanisms that cause this damage, of course, are the typical things that we believe are involved in glomerular inflammation, the complement activation, cytokine activity, et cetera. The point I want to make here simplistically on this one slide, and it's just to remind us of a body of literature, is that there's an increasing body of literature that would suggest that hematuria is not just a marker of IgA nephropathy and glomerular inflammation, but may be a predictor of clinical outcomes. So some recent data would suggest that the likelihood of end-stage kidney disease or loss of kidney function is more prevalent in those patients who have hematuria. On the flip side, there's also some evidence that would suggest that a resolution of hematuria might be associated with a better clinical response. It goes without saying that we've seen that patients with proteinuria, that the degree of proteinuria is a major predictor of outcomes, so I'm not going to belabor that. But the point that was made earlier today, I think, is increasingly important. Even patients with low levels of proteinuria are at substantial risk for progression of kidney failure in their lifetime. And I think that's highlighted best by this, or when we talk about the rate of loss of GFR over time. This has become one of the most commonly shown slides in lectures on IgA nephropathy, which speaks to the fact that this young population, even if they may have relatively slow, and maybe put that in quotation marks, slow loss of kidney function, that followed over extensive periods of time, the majority of these patients are at substantial risk for kidney failure. This is from the RADAR study in the United Kingdom. Dr. Barrett and Dr. Pitcher are key authors on this paper. And I think the simple point in the figure on the right, if you look at the age of diagnosis on the bottom and the annual loss of eGFR on the left, depending on what level of kidney function patients are at when they start, you can see in those red, this is like our heat map from KDIGO about risk. You can see that the vast majority of patients diagnosed are at very high risk of kidney failure unless we can get that annualized rate of eGFR loss, certainly down less than 2 and maybe less than 1 cc per year. So I think it's really a call to action of thinking about this disease as an ominous one. And just as a simple reminder of that, when we think about, this is just an example, and it gets to the controversial question of what is the standard of background care for IgA nephropathy. We know that is changing almost daily as we speak with existing and other medications that are on the horizon. This just, to me, is important from the DAPA-CKD trial, where we know that an SGLT2 inhibitor, dapagliflozin, was added on a background of RASI therapy. As we know, there was a sub-analysis in the IgAN population on the right. Not to belabor numbers, but the point is that even with an SGLT2 inhibitor and RASI therapy, yes, there's clearly a difference and better outcomes in the patients with therapy, but there still is a yearly loss of eGFR an annualized loss of EGFR of 3.5 cc's per year. And thinking back to that previous slide, it still puts patients in a range where I would consider them at substantial risk of kidney failure during their lifetime. So I'm going to flip it over to Dr. Lafayette, and we'll hopefully have some time for some questions at the end.
It's great to be back with you again after such a long absence. So nice to see you. And it's, again, very, very exciting times, as has been pointed out in IgA nephropathy. Again, new insights into pathophysiology have led to therapeutic adventures fueled by regulatory agencies saying that we do have biomarkers that are effective surrogates, such as proteinuria, has allowed influx of interest and money to study this disease. And then in terms of the pathophysiology, the Professor Glassick's thing is, why don't we take these autoimmune diseases and think of them in terms of the immune system and try to get to cure the immune issues, expecting the clinical phenomena of the kidney disease then to abate. And so looking at B-cell modulation makes huge sense in IgA nephropathy. As many of you know, we tried that years ago with rituximab to try to get rid of circulating CD20 cells. That didn't seem to affect biomarkers such as IgA levels or galactose-deficient IgA levels, and therefore did not affect proteinuria or progression rate in our study. But these agents seem to be much more exciting, much more impactful, and have huge promise to prove to be effective agents as we study them in phase 3 now. So as you heard, the rationale for B-cell modification, Atacicept was specifically designed to modulate B-cell activity and was brought into IgA nephropathy with the knowledge that by targeting BAFF and APRIL, you can inhibit both B-cell and function, its maturation into plasma cells, the survival of B cells, the survival of plasma cells, and can expect a reduction in circulating antibodies, and particularly in IgA. So, and I'm not going to my slides because I'm looking at my board there. So again, Atacicept itself has been fully humanized. It's a dual BAFF and APRIL inhibitor based on the idea that if you could fuse the TACI receptor to a FC domain, then you can clear both BAFF and APRIL, which have high avidity to TACI, from the circulation and not make BAFF and APRIL available to B cells, thus inhibiting B cell maturation and survival, and reduce antibody production. So Atacicept, as you can see, is a nanomolar effective inhibitor of both BAFF and APRIL, and again, preclinical data demonstrated it effectively reduced both BAFF and APRIL activity. And in IgA nephropathy, this makes wonderful sense because Atacicept now is targeting that very upstream immunologic cascade in IgA nephropathy, such that, as a slide that Dr. Cooper has put up there, B cell activation occurs in IgA nephropathy where B cells mature, they're antigen or T cell stimulated to class switch and make IgA mucosal surfaces, particularly galactose deficient IgA, and Atacicept can now inhibit that class switching and B cell modification and reduce galactose deficient IgA production, which in turn can reduce the formation of circulating immune complexes, not only by reducing galactose deficient IgA, but now the B cells or plasma cells cannot recognize the increased galactose deficient IgA, so the expectation would be that there's less anti-glycan antibody as well, whether that's IgA, IgG, or IgM based. And if you don't have circulating immune complex, therefore you should have less immune complex in the glomerular mesangium and less incitement of inflammatory factors in the glomeruli and tubular interstitium, such that the hematuria, proteinuria, and eventual fibrosis can be held in abatement. So that's the pathophysiology that would support the idea that atacicept could be effective in IgA nephropathy. And again, this clinical development program has been going on for many years already, and it started with preclinical work just proving that this was a B-cell modulatory agent, but in IgA nephropathy, the first experience was in the Janus study, which was 16 patients, proof of concept, and that study was completed, demonstrated an impact on IgA, on galactose-deficient IgA, on immune complex. So again, that hypothesis was fulfilled. It demonstrated a proteinuria-reducing effect, and it was safe and well tolerated, such that when a further suitor to use the agent could be identified, a more formal phase 2b study could be taken on, which is what we'll discuss in a moment, which is the Origin phase 2b study, which included 116 patients, as you see, and was designed as a week 96 interventional trial, starting as a 6-month placebo-controlled study, where then there was an open label extension. And given the success of the phase 2b program, we're now already full swing with the phase 3 study to try to prove ultimately that this is an efficacious and safe agent. So what I'll present you now is that Origin phase 2b study, which again took a very typical international IgA nephropathy population of adult patients with biopsy-proven IgA nephropathy. They had to be on stable, maximized RAS inhibition for at least 12 weeks. This should sound familiar. SGLT2 inhibitor use was allowed, but this was in the early days of SGLT2 inhibitors, so there's not very many patients on the agent. Again, they had to have more than 0.75 grams per gram of proteinuria or more than 1 gram per day of protein. Actually, let me correct that. They could have a 24-hour urine with 750 milligrams per day, and they had to have GFR greater than 30 mils per minute. Their blood pressure had to be well controlled, targeting 120/80, but if on the day of screening they were just less than 150/90, they can still come into the trial. And again, the endpoint for the trial was 24-week change in proteinuria, but other important endpoints were then 36-week proteinuria, GFR change by week 36, ultimately eGFR change at week 96, and again, biomarkers were checked, such as galactose-deficient IgA1 changes and hematuria changes, and of course, with a constant eye towards safety. And as you can see, this is a pretty representative population with IgA nephropathy. The total patients is 116, which is well supported across the different arms, where there was a dose finding, mainly looking at 75 versus 150 milligrams with a historic 25 milligram to expand the safety of the study compared to 30 placebo patients, and groups all over-recruited slightly. But these are, again, roughly 40-year-old patients, mostly male, as we see in our clinics with IgA nephropathy, good balance between white patients and Asian patients, and again, with overall reduced GFR in the mid-60s, total 24-hour urine protein at high risk, just above 1.6 grams per day, and again, the time from biopsy, about 2 to 3 years. So again, a very representative high-risk population with IgA nephropathy. And again, looking first at 36-week data for the blinded period, when we look at the 150 milligram group versus placebo, you can see that indeed the drug does what is promised to do, that it reduces galactose-deficient IgA a lot, by about 2/3 reduction from beginning and significantly compared to the placebo group. And associated with that treatment, or caused by that treatment, associated with that reduction in galactose-deficient IgA, is a very substantial reduction of hematuria. So among patients who had dipstick-positive hematuria at baseline, and then were followed up at the end of 36 weeks, you can see 80% of them were dipstick negative, and you can say that's just variability, but only 5% of placebo patients became dipstick negative. Again, for the proteinuria reduction, this was done by intention to treat, and you can see that by 36 weeks, there was a 33% relative reduction in proteinuria. If you look at patients who adhere to the protocol, this was closer to 40% reduction in proteinuria. And the most tantalizing early finding was that the GFR was absolutely stable in the patients treated with Atacicept, slightly above baseline, while there was the expected relatively severe reduction in GFR among these high-risk patients with IgA nephropathy, losing about 8.5% of their kidney function just in this 36-week period of time. So again, as we look beyond 36 weeks, you can see that 232 patients were screened, 116 patients were randomized, and again, to their appropriate group, but that patient retention was quite excellent, with more than 90% of patients staying on study, a little disproportionate loss of those patients in placebo, but still the vast majority stayed in, and the overwhelming majority of patients stayed in to extend to open label that occurred after 36 weeks. And then the patients were evaluated at 72 weeks now, all on open label drug, to see how they were doing at 72 weeks, and only 5 patients discontinued during that period of time. So it's pretty good adherence to the study. And the point is that those patients moving from placebo to now Atacicept 150 milligrams open label did the same thing that the patients did when they were assigned to the active drug. That is, that the galactose-deficient IgA goes down as expected by about 2/3. So you get a net 60% reduction in those patients to their 36 weeks. And those patients who are on the drug from the beginning have stable, safe reductions, well tolerated in galactose-deficient IgA for that additional 36 weeks. So again, the drug reduces galactose-deficient IgA very effectively, but stably as well with prolonged use. And then you look at hematuria message, and now you see that there was sustained reductions in hematuria with the group that continued on the drug. There's more and more of them that no longer have hematuria as you follow them out to a year and a half at 72 weeks. And those patients who switched from placebo to active drug are having a very nice, sizable reduction in the number of patients with hematuria, going down by an additional 55% of patients with hematuria. So it's a very nice impact on the biomarker of hematuria. On our main biomarker of proteinuria, you can see again that those patients on the left who continue on Atacicept have further reductions in proteinuria. So they're sustaining more biomarker benefit of proteinuria reduction as they stay on the drug. And those patients again switched to Atacicept. This group had an even more robust reduction in proteinuria in terms of it being faster. So by, again, 36 weeks, they're down nearly 50% in proteinuria. But again, most satisfying is the fact that now at a full year and a half from randomization with continuous Atacicept, there's no loss in GFR. And remember, these patients in the placebo group were on track to lose about 8 mils per minute per year to 10 mils per minute per year, and the treated patients lost 0. And even those patients switched who had lost significant kidney function in 6 months, You can see there's an initial impact to stabilize kidney function, which is entirely stable to 36 weeks. So biomarkers are one thing, kidney function to me, that's another thing. So again, really, really impressive phase 2 studies there. Now again, we are impacting these patients with reduced B-cell activity. We are impacting these patients where we know we're reducing their gamma globulins, their IgA, their IgM substantially, and therefore it's really important to look at safety. And the placebo group compared to the different doses of Atacicept, there's no signal. Okay, so looking at overall adverse events, infections, infestations, other effects, whether mild, moderate, or serious, there's no change. Fortunately, there's no deaths in any patients, but there was really no safety signal through 36 weeks. And then when they go to open label, the event rates are very similar in the open label period as they were in the placebo period. So again, no safety signal, and in the history of Atacicept with well over 1,000 patients treated for various autoimmune diseases, overall there's no safety signal. Again, this is perhaps despite or as expected that, as you see here, in terms of immunoglobulin effects, there is a substantial reduction in gamma globulin. There was no patients who had severe enough hypogammaglobulinemia that it was a concern or needed to stop the drug. Again, the IgA overall comes down and then somewhat stabilizes throughout the entire period of observation, and there's substantial reductions in IgM that are sustained but well tolerated. And again, those overall conclusions is when we combine all the patients with their timeline of active drugs, you see these very lovely effects on reducing the biomarker galactose-deficient IgA, of reducing clinically obvious hematuria, of having a substantial effect on proteinuria, and there's that absolute stable GFR through 72 weeks. And therefore, what we see is that patients, at least out to 72 weeks, demonstrate consistent sustained reductions in galactose-deficient IgA and in hematuria and in proteinuria, that they have a consistent, absolutely stable GFR. These data provide early evidence of long-term, at least 18 months, comprehensive disease control, okay? And that the participants who switch from placebo, at least over 36 weeks, are completely recapitulating what we see with the drug. So again, we've got two populations now, the 90 patients treated from day 0 and the additional 30 patients now treated for an additional 36 weeks, really reaffirming the hope that this is disease modifying and indeed GFR stabilizing. This was well tolerated with an adverse event profile that looks exactly the same as placebo. So that's fantastic. And so this gives us a lot of confidence that the phase 3 study can be safe, that we have good rationale to recruit it, and that hopefully the data will look similar to phase 2. Again, the phase 3 study is very similar to 2B, where it's a randomized controlled trial of adults with biopsy-proven IgA nephropathy who are well treated on baseline therapy, at least 12 weeks stable on RAS inhibitors. They could be on stable SGLT2 inhibitors as well, with more than a gram of proteinuria, either on a spot or 24-hour urine, GFR greater than 30 mils per minute, blood pressure that's well controlled. And again, we'll be looking at 9-month change in proteinuria as our primary outcome for accelerated approval, and then 2-year eGFR stability for long-term full approval with careful attention to subject safety. And so look forward to be able to present that data in a couple years. So thanks for your attention, and we look forward to questions and comments.
Thank you, Dr. Lafayette and Dr. Cooper and Vera Therapeutics. It's good to see everyone. I'm Dio Wagasback. I'm Associate Professor of Nephrology at UT Houston McGovern Medical School and am one of the GlomCon executive team members. So it's my first time seeing you guys today. I'd like to welcome. We have about 5 minutes for questions, so we'll take one.
Great data. I have a couple of questions. The first one is, we know that B-cell targeted therapies have a big impact on vaccine responses. Has this been looked at in animal models, or is there a plan to look at that? And then the second thing is, for this trial, is there a requirement for certain vaccination or prophylaxis?
So I'll start, and then of course I'll give the company representative to really make sure they've checked the boxes. So surprisingly, even though this has a major impact on IgM and then has an impact on IgG, vaccination responses have been studied. They look to be very well preserved, so people do not lose their learned immunity, and they seem to be safe in that regard. I can't recall that there's enough robust data about fresh vaccinations. We generally try to have people be well vaccinated at least a month before they enter the studies, but Kerry may have more data about fresh vaccinations during the study.
Yeah, no, your information is correct, Richard. The one thing I would just emphasize, we have not looked at COVID vaccination response, but this study was done during the COVID pandemic. There were COVID infections across the study, but importantly, there was no imbalance in either the frequency or severity in COVID infections between Atacicept treated or placebo treated patients.
Dr.
But there
Henry?
are no, the patients are vaccinated going into the study, but there's no additional vaccination requirements as in some of the other clinical trials.
Thanks. I'm Bruce Hendry. I'm in London, from London, UK, and I work for Vera Therapeutics. April has clearly the properties you've demonstrated as driving production of IgA, but most things have two sides to them. April is also believed to be a protective factor, particularly in the cardiovascular protection through its interaction with heparan sulfate proteoglycans. So my question is there any work going on to check whether Atacicept might be affecting that protective role of April, particularly in the context of potential long-term use of Atacicept?
Jess, so I think the answer to that question, again, there was an interesting paper looking at April activity and atherosclerosis and suggesting April protects from the development of atherosclerosis. So I think that's an important early observation. It is just that, an early observation. So I think the safety program has to be carried forward. I don't think the data yet is strong enough that as an investigator, or if I happen to be on a DSMB, that I would be looking in these generally young patients for signals, and so hard to study that, but certainly we'll be looking at cardiovascular outcomes and see if there is any signal. It's always a concern, and safety is really important.
One thing I did want to mention is Atacicept, while we've presented the data about efficacy and safety during our IgA nephropathy program, this asset has been under investigation for some period of time for other immunologic renal diseases. And in fact, the overall safety exposure database numbers over 1,500 patients to date. So I think we feel, as far as protective benefits, I'm not sure I can say anything there, but in terms of the overall safety profile, I think we feel quite good about the history record that there is there as well.
Could I make a comment to Bruce's question? You know, I got very concerned about this when I saw that paper came out, so I did a deep dive into it, and it's actually an alternative form of April that's the cardioprotective one, as opposed to what you are blocking. And it's not clear to me at all that Atacicept or any of the other blockers are hitting this alternative form. So it gives me a little bit more relief that we're probably okay. Not 100%, but great.
Yeah, congratulations to you both. I think if the phase 3 turns out to be as effective as the original Origin study, this is undoubtedly going to be a transformative time. In fact, it probably will make all algorithms for treatment of IgA nephropathy obsolete. We'll have to rewrite all of the algorithms. I hope it turns out to be that, and it certainly looks like it's headed in that direction. I do want to reemphasize what I said earlier. IgA nephropathy is an autoimmune disease. You don't get disease unless you have antibody. Antigen is insufficient to produce clinical IgA nephropathy. Therefore, the focus should be on IgG antibody to galactose-deficient IgA, not to galactose-deficient IgA itself. Actually, Berger, in his original description of IgA nephropathy in 1967, called attention to the fact that it was always IgA plus IgG. In fact, he toyed with the notion of, in addition to having his name attached to it, to call it IgA-IgG nephropathy, which would have been a more accurate description. This is not just IgA. IgG is a requirement. And in fact, as many of you who follow the literature closely, Mark Haas at Cedars-Sinai doing confocal microscopy, not standard immunofluorescence microscopy, 100% of patients with IgA nephropathy have IgG co-localized with IgA. Well, she probably reviewed the paper and made critical comments that weren't in the final paper, but I just want to emphasize that we should not lose sight of the fact that there is an autoantibody in this disease.
Yes.
That can be measured. There are techniques.
So let me comment that, because it's a wonderful point, and entirely agreed, and I don't know what Agnes said to you, but I'm sure it's not, I'm pretty confident it's not there in 100%, but it may be on and off at different stages of the disease for sure in enough people. But I do have to say that working with a large number of companies and studies is that it is not factual that there's reliable assays for anti-glycan antibodies. So all we have right now is the agency has only very recently approved galactose-deficient IgA as a reliable test. And I don't know how reliable and reproducible that is, but anti-glycan antibody tests, whether IgG, IgA, or IgM, are not reliable and reproducible. Again, there are some basic science studies showing that these agents do impact anti-glycan antibodies and immune complexes when they are measured, but it's not reproducible, it's certainly not validated, and certainly nowhere near ready for either a prognostic marker in clinical practice or to test these studies. I do hope the companies will get together, use their sera, and study this, look at it in the urine. I've advocated for that for a decade already, so I agree with you, except for it's not something we can just do today and measure it and see if that correlates.
Yeah, thanks, Richard, and I agree. We are in the same point with IgA as we are with FSGS and minimal change disease and anti-nephrin antibody. Great idea, great pathogenesis, no FDA-approved test. Well, I think we ought to be investing a substantial amount of our excess change to create an approved, reproducible, reliable test for anti-galactose-deficient IgA antibody so that 5 years from now we'll be like membranous nephropathy instead of here arguing about how much IgG is in the biopsy, how much IgA.
Agreed.
And now we have a drug that is known to have biological effects on IgA antibody synthesis. So I still am arguing in favor of starting now to emphasize the antibody component of IgA nephropathy, not just the antigen.
Thank you. And thank you guys for the presentation and for lunch.